Hello, friends. Welcome back to another episode of Perfecting PT. I apologize if you happen to be watching this face to face. My background today is a bit janky and basic. My usual place where I record the office space that I use, one of its alarms was going off. And I didn't want you guys to just sit there and have like this beep, beep, beep going on the entire time that we spoke, because that would drive me literally insane if I was the one listening to a podcast like that, and I would hate it. So today will be part 2 of our Fixing Lower Body Pain or Treating the Lower Body series. For anyone who has not listened to the first part, I would highly recommend it. We go over some kind of essential foundational principles for treating the body, in my opinion. We go over some definitions of biomechanics, and we talk about how the body compensates, because a lot of people will say, oh, like he or she's compensating, he or she is doing, and you'll doing something off. But what does that really mean? Because the body can't compensate in an infinite number of ways. It can compensate in many ways. But the ways that it compensates are logical, because the only structures that can assist are structures that have a role in performing a given function. So I know, like, the TLDR of last episode is if the glutes are not adequately performing hip extension, they can call upon the low back to assist or the hamstrings to assist. If the hamstrings are now working double duty, they may ask the calves to help them with some of their knee flexion responsibilities. And if we follow that down the train, the calves, if they're not able to handle two jobs, are going to put more demand on the soleus, the tibialis posterior, or the peroneals. And on the lateral side of the body for side-to-side motions, if the glute med, glute min are not doing their jobs adequately well, they will put added strain on the TFL, added strain on the QLs, and that can propagate down as far as into the peroneals as well. So that's kind of the general overview practically of how I think the body compensates. And there are other things as well, which I'm sure we will get into, especially as we talk today, because my goal of today, I'm going to tell you how I assess everything from the low back down. I believe that it's super important that you have a system that you walk through. And in my opinion, the purpose of the system is to make sure that you cover enough points that you can be confident in the direction you choose to treat, as well as you cover enough points to know you haven't missed anything super important. We're not going to go over the things that I look for like red flags in the subjective, because we can, but that's not the intention of today's episode. So I'm going to go over how I assess the lower body. And I will tell you this: I do it every single time. It doesn't matter if someone has low back pain. It doesn't matter if someone has an Achilles tendinopathy. It doesn't matter if someone has lateral hip pain. It doesn't matter if someone has knee pain, medial or lateral. I find that so many people have the exact same biomechanical limitations and compensations, but how their body breaks down and where they experience pain is unique to them. So starting off, first and foremost, when I am assessing someone's lower body pain, I look at their single leg standing. I have them stand a few feet in front of me. I have them cross their arms over their chest, and I have them stand on one leg without their legs touching. What I am looking for is how well their body can perform co-contraction of all the muscles of the leg and core to provide stability on that one leg. The big things that I'm looking for that are often that go wrong, that point out what's having an issue, I start looking at the ankle, and I look, is the ankle supinating, pronating, meaning is the ankle collapsing in either frequently or aggressively? That kind of points out maybe the ankle itself is having a hard time providing stability. The second thing I look at is what the knee is doing. The knee primarily bends and straightens, and any rotation at the knee is caused from the hip. So I look to see if the knee as well begins to twist and dip to the inside aggressively. And the more you notice with patients, you'll see that just because the knee dips aggressively does not mean that the ankle will follow it, or vice versa. I find that if the ankle is dipping aggressively and the knee is not, it's likely that they have motor control or weakness in the ankle. And if the knee is dipping aggressively to the inside, it's likely that they have poor stability from the hip to control rotation. After that, I have them turn around and I do what's called the Stork's test. I know that not everyone is a fan of the Stork test. What it is with the patient facing away from you and standing, you put one thumb on the PSIS. In my case, I kind of slide my hands on top of the iliac crest, and then I palpate the PSIS on either side. And I'm looking for symmetry. Does it have to be symmetrical? No, of course not. Some people have a slightly longer femur, tibia, their like hemipelvis is a little larger. I'm just kind of taking a look at how they are. And from there, the Stork test is keeping one thumb on the PSIS and taking the other thumb and dropping to the middle of the body a couple inches, and there will be an obvious bony prominence, and that is S2. And what I have them do is I have them march one leg, the leg that I'm holding on to the PSIS or the back of the pelvis, that little nub, and I have them march it all the way up high. Because what should happen is that there should be a slight posterior rotation of the PSIS, and then the pelvis and the sacrum and the hemipelvis will move together, and then the PSIS will drop a little bit further. So I'm really looking to see if there's a smooth glide of that hemipelvis to kind of roll posteriorly on a stable opposing leg. And then I look at the other side. What am I looking for? There are some people who do not have adequate stability in the leg to allow the pelvis to roll and create that motion. So it's just giving me an insight into how stable are they on one leg and what their pelvis does naturally as they move. I'm also looking to see if there is an obvious pelvic dip or a Trendelenburg. I know Trendelenburgs are sometimes hard to see. Sometimes they're easy, but I have found it is easiest for me to be consistent by grabbing the pelvis, having them stand on one leg and seeing what the pelvis does, because it will either shake or wobble or be smooth. And we want it to be smooth and symmetrical on both sides. After that, I look at lumbar range of motion. I look at lumbar flexion, meaning that they are bending forward to reach their toes, and I'm looking at the quality of the motion. Do they do a hinge where they don't allow their low back to round? Do they only round, but they do not flex at the hips? Do they deviate to one side or the other? It's not that any of these is particularly like, I know exactly what's going on, but it points out where the person is comfortable moving and what positions they are avoiding to kind of get your mind thinking, why are they avoiding a given position? Are they deviating to the left because they are like a passive tissue, like a joint or a ligament does not want to be stressed? Or are they deviating to the left because there is some type of muscular issue where there is either weakness or poor control and the body biases the things that it trusts more? After flexion, I have them stand back up, and I'm particularly aware if they get catching on the way back up. So if they bend down and they're okay, but anywhere between half and 3/4 of the way up, they go, ooh, my back, and it catches. That is a hallmark of spinal instability. When I say that, I do not mean that the spine itself is unstable. I do not mean that the discs and the vertebrae are flopping all over the place, because that simply is not true. What I am trying to say is that the muscles that are supposed to coordinate that motion so that the lumbar spine can return to normal from flexion smoothly are spazzing out. And at a certain point, the body, in response to some lack of coordination in those muscles, goes, and they lock up. Okay, so I think that is a key thing that I look for. Then I go side to side. I grab their shoulders while they're still facing away from me in standing, and I lean them to the left with a little bit of overpressure, and then I lean them to the right with a little bit of overpressure, and I see what happens. If there is an obvious deviation to either, not deviation, a limitation to either side, an immediate thought of mine is the thoracic spine. The lumbar spine does have a decent amount of side bending to either side, But the thoracic spine, because of its structure, which again, if we remember from the last episode, structure determines function. Always. Always. You can't just take a structure that is thrashed and assume it to be able to perform the same function to the same degree as a structure that is perfect. So the structure of the thoracic spine is inherently more mobile than the lumbar spine. And so if they have an obvious limitation to one side or the other, it could be that you need to investigate the thoracic spine a little more and possibly provide manipulation or your choice of exercises to help address that limitation to resolve their concern. What I'm really looking for is when they, in addition to that, on the lower side, is when they lean to the right, do they get pain in the right hip or the right pelvis or the right SI? Those are things I'm really looking for. I have often found that that happens because there is a limitation in the hip, particularly hip extension and hip abduction. And I do it to both directions, and I'm looking. Pain on the same side or pain on the opposite side. If we are noticing pain on the opposite side, so if they're bending to the right and they have pain on the lower left, we've got to look at what structures are being stretched. We have the lumbar erectors, we have the facet joints on the lumbar spine on that side are being gapped. We have numerous things going on that could be contributing to their pain. If we have pain on the same side, why doesn't that side want to close down? Why doesn't the body want to allow that much load to be placed on that side without pain? After I do that, I do extension. I'll grab them by the shoulders. I'll gently kind of give them a little poke in their back with my hand, and I'll say, go and lean backwards, and I'll give them a little bit of overpressure. It's super common for them to experience discomfort right at like L4, 5, L5, S1, where they're like, oh, not my favorite. So am I expecting that to improve greatly? Is it anything particularly useful for me? I don't think so, because like we talked about last time, if the low back is compensating for hip limitation issues, L4, 5, and L5, S1 are going to be hammered into extension anyways, which is a big reason why they tend to degenerate first. Most people, their people come in and they're like, oh, I got problems L4, L5, L5, S1. After I do standing range of motion in the lumbar spine, I move on to having the patient sit down. A key thing to remember, if someone has or supposedly reports low back pain or pain across the pelvis, and you take them through full range of motion, lumbar flexion, side bending to either side, and extension, and they have no pain whatsoever, in my opinion, it is not a back problem. It is a hip problem. And I find that frequently where people come in and the doctor will say, oh, they have a pinched nerve or they have a disc in their back. And they're able to have full motion in all directions of the lumbar spine without any reproduction of their pain. I am immediately starting to look away from the lumbar spine as being a problem, which I generally do. I think the lumbar spine is generally a victim. And I am looking to other locations that would result in the low back having to handle more load or stress. Once I have the patient sit down, I am looking at ankle mobility. I do what's called a Taylor swing. If you're familiar with that, all it means is with the patient in sitting, you grab their foot. I always have them take off their shoes. If I didn't mention that before, I always have them take off their shoes before they do single leg stance. Always. And I grab the foot and I take the ankle. I put my thumbs right on top of the talar dome, and I just push their foot backwards to feel the mobility of the talocrural joint, which is the joint between the tibia and the fibula coming down on the shin, and the talus, which is the top ankle bone. If there are limitations there, they are important. I have had patients that I work with, as well as patients that my mentor has worked with, that have chronic low back pain. And everything seems to be pretty good. And their low back pain is caused because they have janky ankles that are not moving or working well. We address those, and suddenly they come back and like, I have no back pain. Correct. We have to assume that when we are treating the low body, everything matters. The joints on the same side, the joints on the other side, the joints above, and the joints all the way below, clear down into the foot and ankle. Does that mean you have to address everything to where it's absolutely perfect before they get results? No. But it does mean that if there's something obvious about any of the low back, hip, knee, or ankle joints, they should be addressed to try to optimize the function of the lower body as a system. So when I'm doing that, gonna think out loud for a second. You guys are probably going to want to hear what I choose to do for treatment as we go along with this. So I will throw those out as well. Although the intention of this podcast is not to discuss treatment specifically. That was going to be the next one. I will include them to kind of give you a teaser to think about, so you know next time I bring them up, it's not the first time you've heard of them. If there is limitation in the talocrural joint, the joint end feel becomes important. When you are taking the ankle and you are gliding it backwards, is there a resistance that you can push through, almost like you're trying to push through a really tight muscle? Or is there a resistance that's more like a block where you kind of push the ankle back and it goes conk, 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 conk? The simplest way to see if it can be fixed immediately is to perform a talocrural distraction manipulation. I generally do that. So when I'm telling you treatment interventions, I do not mean I'm having the person go from sitting and assessing immediately to treating that thing. I am not. These are things that I will do after I finish my assessment. I'm just pointing out how I would address those in the first place. So if there's a talocrural dorsiflexion restriction, I will do a talocrural distraction manipulation, which looks like someone laying down on their back, grabbing their foot, getting them into a position where it's taking them into dorsiflexion to where there's a little bit of resistance and doing a yank to manipulate that joint. After I look at the talar swing, I also look at the subtalar joint. I grab the tibia and the fibula and I cup the calcaneus with one hand and I wiggle it around to see if it moves freely and smoothly into eversion and inversion. And I look at that on both sides. Okay, both sides should move the same and they should move evenly. If they're both janky, if they both are limited, the same, I still address them. I think that there are joint mobility and range of motion norms for a reason. So if someone is equally limited in one direction on both feet, I don't assume that's their normal. I manipulate it, and then I see if it improves and if they feel better. If they don't, I'm not just sitting there like, I have to manipulate this. I have to fix this. It may be their normal, but I don't assume if I think that something is limited compared to normal, I will treat it until it appears to be their normal. After I look at the subtalar joint, I look at their navicular mobility. So I cup the foot, like thumb over the top of the talus, hands underneath the calcaneus. I grab the navicular with my other hand and kind of pinch it with my thumb and my index finger, and I wiggle it. And you may say, Nate, you can't feel that. Well, if you feel enough of them, you'll feel it. And if you compare both sides, you will also feel it. And I would not underestimate the value of testing it, because not everyone's going to need it, but there's going to be someone who does. And if you don't look for it and you don't find it, you will not be able to treat it. After I look at the navicular, I jump over to the cuboid, grab that, wiggle it around a little bit and see how it's moving as well. And I grab the foot the same way. I kind of wrap a thumb over the talus and a hand on the calcaneus, and I grab the cuboid by the base of the 5th and 4th metatarsals, and I wiggle them. And that's just looking at the foot. After the foot, I don't assess the knee, the hip, or anything like that mobility-wise in sitting. I move on to manual muscle testing in sitting. So I will do dorsiflexion, manual muscle testing, I will do tibialis posterior manual muscle testing, which is, sorry, a little bit of water. Sorry about that. I will test dorsiflexion. I will test tibialis posterior, which I do very intentionally. I grab the person's ankle. I bring it out towards me a little bit because I'm sitting in front of them. And I take their foot and I have them point their toes all the way down. And then I have them invert it so that tibialis posterior is isolated as best as it can be. And then I push. Often garbage, absolute dumpster fire. A lot of people's tibialis posterior is absolutely trashed, which is a big reason they have pain, because the tibialis posterior. So we'll kind of go over the patterns of compensation. Why would it be trash? Well, if glute med cannot do its job adequately, okay, the adductors also help to maintain the alignment and stability of the leg, as well as the tibialis posterior, because inverting the ankle will externally rotate and stabilize the knee. Sorry. After I do tibialis posterior with full plantar flexion and full inversion, then I check the peroneals or the fibularis group, and I do the exact opposite, only in the inversion side. Sorry about that. I have them plantar flex, and then I evert. They have to maintain plantar flexion the entire time. If they start bringing their foot up into a more neutral position with either inversion or eversion testing, they are compensating. And so that needs to be taken into consideration. After I check the ankle, plantar flexion, inversion, eversion, I also do knee extension or kicking and knee flexion, which is bending. That is rarely a problem. And even if it is a problem, let's say I have a lovely lady in her 70s, and she goes and she's got knee arthritis, and she goes to straighten her leg. She says, my knee hurts. I believe that it does hurt. And sometimes there is weakness of the quads, but I often think that the knees are overloaded because they have excessive weakness elsewhere as well that needs to be addressed. So after I do knee flexion and extension and sitting, I do hip flexion and sitting. I have them put their hands behind them on the table and lean backwards slightly. It makes it a little easier for them. Have them lift their knee, give it a good push down. And this one is, in my opinion, rarely diagnostic. I think that oftentimes people have facilitated hip flexors. I don't think you really need to train hip flexors. I think they are naturally become tight and tonic, and you use them all the time because of how we sit and walk and lean forward and do all sorts of different things all the time. But that is how I conclude the sitting manual muscle testing. So quick recap in case anyone's lost. I have people start facing me, shoes off, and I have them stand on one leg to see if they can provide stability. After that, I have them turn around, and I do the stork test, which is essentially holding onto their pelvis, palpating 1 PSIS and S2 on the sacrum, and picking one knee up as high as they can, marching it, to kind of see how their pelvic stability is and how they move. Then I look at their standing spinal range of motion, bending forwards and coming back up, bending to the sides, and leaning backwards. Then I have them sit down. I assess the ankle joint mobility, like I said, and then I assess the manual muscle test of the lower legs, the ankle, the knee, and the hip flexors in sitting. Then I have patients lay on their back, and I check out their straight leg raise. I look to see if there's a deficit in either side. If there is a deficit, particularly on the side of weakness, if it is severe and they may have come in for back pain, I may potentially be looking at a disc that is bad. If it's been a long-standing issue and they have bad straight leg raise on one side, it may be a dural issue because there's either scarring, inflammation, or long-standing stiffness that is restricting dural mobility. But another thing that I see frequently, going back to the patterns of compensation, if the hips do not extend well because of the glutes have a couple jobs. The glutes are glute max is what I mean when I say that. The glute max should be the primary extensor of the leg, and it also has a prominent role in external rotation. And the glutes, on most people, are massive. On me, I always tell my patients, I always joke with them, I say, God didn't give me glute max. He only gave me glute mins because I just wasn't blessed that way. But because the glutes should have a dominant role in external rotation, I often find that if the glutes max is not working well, the piriformis will tighten up to try to compensate for the portion of external rotation that the glutes are not doing. And we know that if the piriformis starts to overcompensate, it tightens up or gets inflamed because it's pissed. It can limit straight leg raise because of added pressure on the sciatic nerve that passes right underneath it. So that's kind of going through my head as I'm doing a straight leg raise. After I do a straight leg raise test, I always check knee flexion on either side for joint mobility. While they're laying it on their back, I'll grab their knee, I'll bring it up, I'll bend it up. And when I get to end range, I am pushing on flexion. So the knee's bending as much as I can do it, and then I bend it. I see how it feels. I bring it back out so it's bent about 90 degrees. Unless your patient can't get to 90 degrees, then I straighten it out more. And I give the tibia a gentle internal rotation, and then I take it back into flexion to see how they respond. Bring it out, gently external rotation, and bring it back in. What I'm looking at, we know that if you rotate the tibia and then go into extension, it biases load onto the medial or lateral side, which is going to bias the meniscus as well as the cartilage on that side. And there will be people that they have no pain whatsoever when you just crank on their knee in flexion as long as it's straight. But then as soon as you rotate it and you barely start going, they're like, ooh, that hurts. And so I think it's indicative. Again, we're looking at what is hurting them. And then we're trying to figure out what the body is doing that would lead to that area undergoing greater stress passively or greater load actively. After I check the knee joint into flexion, always check the knee joint into extension. I lay their leg out flat. I put one hand on the front of the tibia and one hand on the distal femur, and I put some gentle pressure into the knee to push it, and I see how they respond. If they have pain on the front of the knee, I am assuming that the joint does not want to close. And what I am thinking needs to happen is that we need to do some knee, so tibiofemoral extension, so knee extension, graded mobilizations. And what that looks like for me is again, we are doing these interventions after we finish our assessment, but I have the patient lay on their stomach with their foot off the table so that the toes aren't sitting there limiting the knee from going into extension. I grab the medial distal femur, and then I take my palm and I go on to the medial proximal tibial plateau, and I am gently mobilizing that to facilitate an improved screw home mechanism. And if they have knee flexion limitations, which can be from capsular tightness. So again, you notice when you either rotate their knee and bend it, or you just grab the knee and bend it, it's just really stiff. Then I would do hook lying, anterior to posterior tibial glides on the proximal tibia, on the medial or the lateral side as needed. And then I will have them flip over on their stomach. I will bend their knee for them. I'll put their ankle on my shoulder, and I will work those same graded mobilizations while they are prone with their knee bent. After I look at the knee bending, I go to the hip. The hip, I only do one thing. I look at their fader, Fadir. flexion, adduction, internal rotation. This is the most limited, in my opinion, in people who have low back, hip, knee, even Achilles issues. And what I do is I take the hip and I put it into full flexion. So I, crank it up comfortably. I'm not trying to make someone scream, but I push their hip all the way up into flexion, and then I scour it to the inside. One of three things is going to happen. One, it will move fine, nice and smooth. Both hips should move the same. I can't emphasize this enough. When it comes to biomechanics, if joints are capable of doing the exact same motion with the same quality, the same control, and the same strength, there is absolutely no reason that any part of them should be overloaded or under added stress compared to any other tissue, and therefore they're unlikely to have pain. So number one, it'll move smooth. Number two, during the first half of the arc, you will hit like a honk, like a clunk. Not that the joint pops, but that it just kind of hits a stop. Or it'll feel like instead of going smoothly, it'll almost feel like there's a speed bump where the hip will start going and it'll have to like move out of the way before it can keep going. If there is that kind of restricted initial scour, I do what's called a hip bump manipulation. It is also referred to as a Ufer manipulation, and was discovered and created by Gail Malloy. I can put the research article in the show notes. But what it is you lay the person on their side with the affected side. So if their right hip isn't moving well, the right hip is going to be up in the air. I bend both of their knees, so I kind of tuck their feet underneath their butt a little bit. Then I take the top leg and I bring it a little more into flexion. And I'm looking so that the angle between the torso and that upper thigh is between 45 and 90 degrees. From there, I will use my hand. I'm standing behind them. The affected hip is up, and I'm taking my hand that is closer to their upper body, and I'm grabbing the iliac crest, and I'm taking my opposite hand, and I am skipping my hand off of the greater trochanter from an angle that is perpendicular to the femur. Then I'm going to stand a little more towards the head, and I'm going to skip again off the greater trochanter from an angle that's about 45 degrees higher. Again, we're going to talk all about these next time in interventions to address the lower body issues. So that's what I do if the hip has issues in the first initial part, third to half. If someone does, and oftentimes their pain in that initial portion in the front will be in their groin or on the outside of their hip or in their back. Okay. If the discomfort or limitation is in the latter portion of the scour, I often need to treat the piriformis. And the reason being, if, like we talked about, the piriformis is compensating, or the other small external rotators are compensating for a glute max that is not doing its job adequately well, and they have increased tone, the joint will inherently be slid forward and rolled back slightly, which will limit its ability to roll forwards because it runs out of room, because the head of the femur, in order to roll back, would have to push against and stretch these small external rotators. So if there is an issue with the latter half of the scour, I will do various piriformis interventions. A couple of my favorite include a piriformis muscle energy technique that I do with the patient in supine. I take their leg and I bring it up so that their knee is at so that their hip is at 90 or a little greater. I lean into that leg So I'm almost like leaning over the patient using my body weight to stretch the hip into adduction, horizontal adduction. And I don't just crank on them. I go and I ask them, I said, what do you feel? Well, let me know when you feel a mild to moderate stretch, at which point I hold that stretch for 20 seconds. I tell them to gently push against me. So they're horizontally abducting the hip for 10 seconds. And then I have them relax. I take up the slack for another 20 seconds. They push for another 10, and then I take it up for a final third time and I stretch them. And you'd be amazed how often that helps improve the scour and gives their body a chance to at least temporarily work with an altered nervous system that you can begin to change to accept these changes longer term. After I do a scour on either side, I do not do a Faber, flexion, abduction, external rotation. The hip, when it is having issues, generally externally rotates and abducts. That's the place that it goes to that is generally most comfortable. Okay, we know that abduction and external rotation is an open packed position for the hip. So it's often the place that the hip goes to naturally when there's issues, and it isn't really going to be problematic clinically, in my opinion. And that's most of the time. There will be some patients that you do need to look at it, some patients who do need to have it addressed, but I just find that 80% of the time it doesn't. After the hip, I am looking at the SIs. And I know there are some of you listening who say, Nate, the SIs don't move. The SIs move very little. Doesn't matter how much the SIs move. I am aware of what the research says. I had your same concerns, and I had your same doubts and reservations when I first started working with my boss who intervened at the SI. And there was only one problem. And it was that I didn't get as good of outcomes as my boss who did look at them. And he got them so consistently and so predictably that I decided to change my tune. So what I do, it's nothing crazy. And it is not the Laslik cluster. Because I don't think, again, if the SI is causing pain, what limitations is the lower body having that would cause the SI to take added stress and load? Like the SI, even if it does have pain, the SI probably isn't the problem, the victim of multiple problems. So what I do with the patient, again, still supine, I ask them if I can touch their hips, and then I take my palms and I put a palm on each ASIS and I lean over and I angle my forearms about 45 degrees into the ASIS on either side. And I am not holding the pelvis with both hands. One hand, so let's say I'm going to test with my right hand, their left hemipelvis. I'm going to put my right hand on their left ASIS and my other hand on the opposite side. And I'm going to drop my weight diagonally toward the spine with that right hand. And I'm going to kind of get to where it runs out of room, and then I'm going to give it just a little bounce. And normal would be that it moves easily and smoothly. Kind of take it down to that space, you give it a little bounce, and it's springy. Not terrible. I'm not trying to like down into their pelvis. It's just enough weight just to kind of start rolling their pelvis, kind of rolling it, and then give it a little bounce, and then go to the other side. If there is a limitation, and if you, again, once you feel enough of these, you will find them. If there is a limitation in the pelvis, you have a couple options. If it feels very restricted, meaning you go to push it down and you're like, man, this left side doesn't move at all, and the right side is springy. Well, on that left side, if it doesn't move at all, that is when I do a long axis distraction manipulation of the whole leg. And I do that by having them lie down on their back, bending the opposite leg up so that they're in half hook line with that leg, taking the other leg, giving it a little bit of flexion, internally rotating it, adducting it slightly, and I give it a little pull, ask them if it's painful at all, and if it is not, I perform a grade 5 manipulation, and then I reassess the mobility. If it just feels stiff, I would encourage you to double check the hips, because oftentimes there will be an SI that is made stiff because of a hip limitation. And if you address the hip limitation, which we've talked about, like a fader limitation, a fader scour limitation, you'd be amazed that if you address the hip first, you may go back and the SI loosens up and you don't have to do a manipulation. But I am looking at the SI in that way. One, if there's an SI limitation, make sure you have cleared the hips for the fader really well. Okay, if the faders both look good or feel good and the SI is still limited and it's very stiff, I do a long axis distraction manipulation. If it's kind of stiff, I do a long axis distraction graded distraction, just like a mid-grade, and I just hang out there for a minute or two. And if that is still not helping at all, I do what my boss calls the Chicago technique, where I will take one hand, I will lean over the patient and take my hand that is closer to their torso, and I will slide it under their low back, and I will cup the SI on that side. And then I will take my other hand that is closer to the feet. And again, I'm leaning over the patient, and I am taking my palm, grabbing the ASIS, gently posteriorly rotating the hemipelvis, and then I'm sinking my weight into it to create a posterior distraction or posterior mobilization. And they're just breathing. I have them take a deep breath. When they breathe out, I follow it up with some gentle graded mobs, and I do that and I reassess. At this point, I do my final mobility and manual muscle testing that will involve the patient moving quite a bit more, because they'll have to roll onto their sides and their back. I always try to do side-lying hip abduction testing, but there are some people who just can't tolerate laying on their back. So sometimes I can't do the testing for hip extension and like passive and active range of motion that I would like to because of pain. For hip abduction, I have them roll onto their side, and I ask them to make their torso and their legs very straight in a line. Almost always, I find that people do not lay straight. Their hips end up being flexed slightly. Not terribly, maybe 10, 20 degrees, but it's enough that they are going to compensate when they try to lift up their leg. So I give them a little help. I kind of put a hand behind their pelvis, and I kind of help pick up their legs, and I tell them to just kind of bring their pelvis forward and their legs back. And without fail, they say, "This is straight?" And I say, "Yes." And like, I feel like I'm bent over backwards. Okay, which in my opinion is another indication that there is some type of muscle balance, or rather muscle imbalance, where you have excessive tone or increased tightness and restricted motion in the hip flexors, so in the psoas and the iliacus. Once I have them like that, I ask them to lift their leg. Without fail, one of two things or both things will happen. They will attempt to lift their leg, and their pelvis will immediately roll back towards you like they're falling onto their back from their side. Or if they can keep their hips vertical on their side, their leg will drift forwards. Both of these, in my opinion, are signs of poor motor control and the need to compensate in order to accomplish a task. Normal should be that the person can lay straight, perfectly straight, because the hip should be able to extend to zero. Past that, but they should be able to get to zero, and they should be able to lift their leg straight to the outside, which would be straight up or even slightly behind them. If they can't even maintain that position and lift their leg, it kind of already tells you what you need to know. But what I do is I correct them. I roll them back onto their side. I may even kind of put a hand on the hip and kind of maintain the hip position where I want it. And I say, relax your leg. Let me kind of have your leg. And I bring their leg up into abduction, true abduction without flexion compensation. And I bring it slightly behind them, just a little bit. It doesn't have to be this big thing behind them, but straight up to the side and just a little behind them. And I let go. And if they drift, which a lot of people do, I mean, I can still push on it, but I know what they're going to do as soon as they get added load. They can't even hold the weight of their leg up without compensating. So I sometimes even have them almost roll partially onto their stomach. So they're half onto their stomach. So they have to lift their leg up, and then I push. And without fail, it is almost always garbage. People have very poor motor control and like proprioceptive awareness of hip abduction and extension, and they have very little control over it, which I just said. So abduction is likely to be garbage, and it may even be worse on the side that does not have problems. Do not overlook that. Both sides of the lower body especially have to be able to do the same thing. The lower body does not have the luxury of the upper body, in the sense that the lower body is always working. You are standing, you are sitting on it, you're walking, you're running, and your body, both sides need to be able to do the same tasks equally well, or over time something will break down. So don't negate, like right hip is weak and they're having pain on the right side, right low back, right hip, right knee, right ankle. It's like right side's weak, but the left side's weaker. It's like, well, that doesn't make sense. Of course it does. It could very well be that the body is offloading from the even weaker left side onto the right side, and it's pissed about it. You can also have more weakness and pain on the affected side because it can't handle the portion of its job in walking and standing and doing all these other stuff that it needs to do. So abduction is almost always a problem. And then I have them lay on their stomach, have them roll over, and I do some passive testing first. I put a hand on their sacrum and I just kind of hold their pelvis down and I just bend their knee just to like see how the quads are, particularly the rectus femoris, because it's a 2-joint muscle. And what I'm looking for, particularly in patients with low back pain and hip pain, you will start to bend the knee and you will either see or feel the person's hips start to, so if this is them laying flat, you see their hips start to lift. Their hips are lifting to try to accommodate the length that the rectus femoris does not have. Okay, so this is another indication that the rectus and the hip flexors, the psoas and iliacus, are compensating and they are overactive because of some weakness or muscular imbalance. And I check both sides. Again, they both need to be the same. And then I bend the knees, both of them. After I've checked knee flexion, I bend them both up to vertical if they can tolerate that. And while laying flat, I let them drop to the outside. Do both hips have the same amount of internal rotation in prone? If they don't, again, we're looking at, this is kind of to cue us in again. We may have noticed during the hip scour for flexion, adduction, internal rotation, we may have noticed that that was a little stiff during the second half. This kind of cues us in again, like, oh yeah, it is still restricted on the same side that the scour had an issue. So it is kind of a confirmation to what you're already suspecting from a previous test. Last but not least, hip extension, which again, will almost always be garbage. Same thing, I take my hand that is closer to the torso and I put my palm right on the sacral angle. So what do I mean by that? I mean that you have the PSIS on either side of the pelvis. And then if you go down the sacrum is shaped like a big triangle. It curves down to the tailbone, and I put my palm right on that angle. I'm not grabbing their butt cheek. Like, don't be weird about it. It's more like to the middle than that. And I just put my palm right on that sacrum so I can hold their pelvis down well. I hook my hand under the knee. The knee is bent, so the foot's up in the air, and I am just extending their hip with their knee bent, and I am feeling how far it goes. I'm also looking to see if their hip has to move, if their pelvis rolls, if they want to like roll, arch their back. I am seeing how their body responds to passive hip extension and seeing how much it is. Is it tight? Is it locked out? Does their body start going into funky positions? Does it drift to the outside? Like, does it drift laterally? I think that's a big indicator that the TFL is tight and may need a little bit of work. And I do that on both sides. Once I have done that passively, I ask them to do it actively. So again, I hold their pelvis down. I ask them to hold their knee bent, and I ask them to try to lift their leg off the table. Again, there are a couple compensations that I notice. One, they will arch their back immediately to try to pick up their leg. That's one compensation. Two, they will try to leverage off of the opposite hip that will flex. So if I am looking at their right leg and they're laying on the table, their left knee will push into the table and flex the hip so that the left hip will come off the table just so the right hip can get off the table and extend, even though it's unlikely that it's actually extending. And another compensation is they will immediately get a hamstring cramp. All of these, in my opinion, as well as just having active range of motion that is less than the available passive range of motion, are indicative that the glute max is very poorly controlled and or weak. Okay. So after that, I generally have them sit on the edge of the table, flip back over, roll back over onto their back, like just get into a comfortable position because we're going to talk. Biomechanically, these are things that I see wrong. And if I had to tell you the things that I see wrong most often in people that have lower quarter pain, low back, hip, knee on either side, knee on the outside, knee on the inside, ankle pain, Achilles tendonitis, patellar tendonitis, greater trochanteric pain syndrome, which we also know as glute medius tendonitis. Like, almost all of these people have terrible hip extension range of motion. They have horrible hip extension strength. They have bad hip abduction strength and range of motion, and they have very poor single leg stance. Now, that means that there are really very few goals that need to be addressed with treatment. And that means that we need to improve hip passive range of motion into extension. We need to improve hip active range of motion into extension and abduction to offload the spine and other structures that would compensate for those limitations. We need to improve single leg stability. And we likely, it's always good to be strong and improve strength of the lower body generally. So those are the kind of muscular limitations. Joint limitations I find most often are they will have a knee that will not flex all the way. One of their knees will not flex all the way. One or both knees will not be completely straight. Just because you can take someone's knees, this is a little aside, just because you can take someone's knees and put pressure into them does not mean that they have the same motion. I apologize that I missed this. I will do better next time. After I push down onto their knee with both hands, I will pin the distal femur with them on their back. I will grab underneath their Achilles, and I will try to leverage their foot up off the table and see if that brings on any knee discomfort. Even if it doesn't bring on knee discomfort, if the motion is not the same, I look to address that. That is a hugely important thing, I think, for older people who have knee arthritis. They lose like terminal knee extension much sooner than they lose knee flexion. And if there is lacking knee extension, we know that there will be greater knee thrust every time they walk, because we know that a normal knee during walking for normal gait should extend between 5 and 0 degrees. So if one of their knees is higher than that, or both of them are higher than that, I believe that needs to be addressed. I'm going to pause the show for a second just so you guys don't sit here and look at me thinking. I'll jump back on in 1 second to see if I missed anything. Otherwise, that is how I assess the lower body. I'll see you in just a second. I can't think of anything else that I would add into my evaluation right now. Occasionally, not often, but occasionally I will also do dural slump testing. But unless they've had a trauma to the back or the hamstring, especially like repeated hamstring strains, a long-standing back injury, I don't think that there are a lot of dural issues. And I think any dural irritations are caused by excessive load and compensations, due to compensations, sorry. So quick recap. I have the patient standing, facing me, shoes off. I look at their posture. I have them stand on one leg with their arms crossed. I have them turn around. I do the stork test where I'm holding onto their pelvis, PSIS and S2, picking up their knee all the way up to see how the pelvis moves, how stable they are on each side. I do spinal range of motion. I have them sit down. I assess ankle mobility, talocrural, subtalar, navicular, cuboid, and then I do the manual muscle testing that I can do sitting. I do dorsiflexion, plantar flexion inversion, and plantar flexion eversion. I do knee flexion and extension and hip flexion. I have the patient lay on their back. I look at the straight leg raise. I look at knee flexion and extension. I look at the hip scour. I look at SI mobility. Then I have them lay on their side. I look at hip abduction strength on either side. Then I have them lay on their stomach, and I look at knee flexion in prone on either side. I look at hip internal rotation, so knees bent, feet dropping out on both sides in prone. And then I also do passive and active hip extension on either side. So that is everything, guys. And I feel the need to bring in one other point. Like, I think posture matters. It's not that it matters because you need to change it. It matters because it gives you insights into the position that the body is most comfortable maintaining. And it allows you to then look at, okay, well, in this position, like, why would the person be so comfortable in this position? Like, how can we get them out of this position? Why wouldn't they tolerate other positions? So it's more of a peek into how the body subconsciously orients itself for most efficiency and comfort. But thank you so much for listening to this. I hope it has been useful for you. The next one that we're going to go over is exercise selection and manual therapy interventions based on these limitations that you find. And I'm hoping that after that, the plan is for me to upload some videos. I'll try to do a Spotify video if you have access to that, but I'm also working on getting all the videos up on YouTube, and getting out more reels. I'm hoping to maybe use my mentor or just me and do some demonstrations of different techniques so that you have a better understanding of what I'm doing. But as always, guys, I just want to say thank you. If you're listening to this now, it comes out tomorrow because today's July 20th, and we just hit over 1,000 views on the podcast, and I'm so appreciative. I am. I'm not gonna cry. I'm gonna hold it together, but I'm just super appreciative of all you guys being willing to listen. And again, if any of you guys would be willing to come on and share your experience, help me learn, help other people learn. It would be a great opportunity to get to know one another and to share what you have to share with the world. So if you haven't subscribed to my Spotify, YouTube, or Instagram, I would really appreciate it. And hope you guys take care. As always, happy to have you here.